7:31 by Verizon time, so we'll get started here. Thanks everybody for coming and joining us for Phoenix Children's Grand Rounds. It's my distinct pleasure to introduce a friend and colleague of mine, Dr. Shiraz Maskatia. Dr. Maskatia did his undergraduate work at University of California at Berkeley, go Bears. Then he did his medical school at University of Chicago. He then did residency back on the West Coast at Stanford, where he's a resident of pediatrics. He then came to Houston to do his fellowship in pediatric cardiology at Texas Children's and Baylor. That's where I first met Shiraz. He did an extra year of training in advanced imaging, including fetal echocardiography. He then joined faculty at Baylor and Texas Children's for 8 years, which is why I had the pleasure of working with him. And then he was recruited to Stanford 8 years after his work in Baylor. He's been on faculty at Stanford for 8 years. He has already risen to the ranks of a clinical professor of pediatrics, not an easy accomplishment. And he is the medical director of the coronary artery anomaly program and associate medical director of the fetal echocardiology and pediatric echo lab at Lucile Packard Children's Hospital in Stanford. You'll see Dr. Maskatia is the recipient of several awards and accolades in the field. He's an excellent researcher, an excellent clinician, and one of the better fellows we've had at Texas Children's. There's a few graduates here as well. So it's my distinct pleasure to welcome Dr. Shiraz Maskatia to talk about the left side of the heart from the Sinister to the Gauche. Welcome.
Thanks, Wayne. It's a huge honor to be here. And it's so fun to see colleagues from around the country that I've sort of had relationships with over Zoom, over email over the years, and actually get to meet people in person. I was joking around with a colleague of mine at Stanford that I actually know a lot of people in the Phoenix Children's Division, and I think it's because, you know, being between Texas and here, and Arizona being between Texas and Stanford, and Arizona being right in the middle, it sort of attracts from both sides. So I think that's probably why. But it's really nice to be here. So, you know, throughout history, left and right have always been diametrically opposed, right? Whenever you think of something that's leftward, the opposite is something that's rightward, and for good reason, right? There's the left side and the right side, but it's not always that simple. And we know that in pediatric cardiology because we're big fans of morphology and what defines something as rightward, what defines something as leftward. And it's actually, we know that it's not that simple in congenital heart disease, but it's also not that simple in terms of the origin of the terms left and right. In fact, when, you know, Arizona being the politics what they are, we well know that left and right are often not diametrically opposed, and there's a lot of gray zone in the middle, and people fall on both sides, and so there it's not really sort of as close of a diametric opposition as you would think. The word left comes from Old English, which meant weak initially, and it was used to designate the weaker, non-dominant hand. Whereas the word right, and if anyone knows Spanish, you know that the word straight and the word right are the same. So anyone sort of learning Spanish for the first time is really confused because are you saying go straight or go right? And so that's where the word right came from, is straight, meaning not bent or not bent or crooked, which is a little bit odd. So the origins of the word left and right are actually not opposites. And you can see this in popular culture, right? Right means good stuff. Do the right thing. Getting the right stuff, right? The kids are all right. You got to fight for your right to party, right? So it's like right stuff. And so right is oftentimes good. And so left has often gotten the short end of the stick for good reason. Left means leftover, right? Remaining, leftward. Lefty, southpaw, departed. The word left in Italian is sinestro, right, or sinistra, and gauche, the word for left in French, means gauche, and so these sort of terms have been associated with left, and in fact, sinister is from the Latin meaning left. Sinistre or sinistre in Old French, meaning false or unfavorable, which then came to mean sinister in English. My 10-year-old son is obsessed now with Mario Kart. and every single day we have multiple conversations about Mario Kart. And his favorite character today is Wario, who's like the evil Mario with a mustache. So all the evil characters have mustaches, and those are that seem to denote like evil things. Whereas Gauche is originally did replace Sinister in the 15th century of French. And then there was some influence from, I don't see Chris Knoll here, he'll get me for this, but there's some German influence, which to that word as well, but initially came from the word from the Old French, meaning to tread or to deviate, and now it's come to mean awkward or clumsy, but has origins in left. And some of your, you can see on the left-hand side of the screen, the left bank or Rev Gauche, and some of the best memories that we have of sitcoms. So the most historic sitcom moments over the years have been these awkward gauche moments. And so in popular culture, Sinister and Gauche always have really, really prominent roles. And the left side of the heart is the perfect example of how Sinister and Gauche come together, because these diseases can be sinister. And we'll go through a bunch of them today, and I hope to, over the next hour, convince you that the left side of the heart really can involve some sinister diseases. And frankly, a lot of our therapies, a lot of our clinical pathways, a lot of the ways in which we treat these sinister diseases are quite gauche, are awkward, are clumsy, and are difficult to get through. And that's probably a good introduction to sinister diseases and gauche therapies is coarctation of the aorta during fetal life. This is for the fetal sonographers and the fetal cardiologists, the neonatologists, the MFMs in the room. This is our Achilles heel. This is where we really, really frequently fall short. And part of it has to do with fetal anatomy and fetal circulation, the presence of the ductus arteriosus, supplying the descending aorta during fetal life, and the fact that when after the babies are born, the ductus arteriosus constricts, and there's always some of that ductal tissue on the aortic arch. So we all know that you can never fully rule out coarctation during a fetal echocardiogram. And so what this sets up is a wide the different options of outcomes in patients who have left-sided and right-sided disparity. If you have a fetus who has a predominant right side, that fetus could have mild disease, could end up having mild coarctation, could end up having critical coarctation, could end up having mild aortic, and end up having pretty significant mitral and aortic valve disease, or that could progress all the way to hypoplastic left heart syndrome. So right-left discrepancy is a sinister disease. It's one of these things where it could really present in a number of ways. We're going to start off with critical coarctation. These are data from a seminal paper by Mike Quartermain and published in Pediatrics in 2015. If you haven't seen this paper, I really encourage you to do so. It's almost 10 years old now, but it really was a seminal study looking at the STS database. So these are all patients who had surgery. So this is all really significant disease. And what they found is with isolated arch obstruction, only 21% of them were diagnosed prenatally. Right? And these are neonatal arch obstructions. These are infants who got surgery in the neonatal period for arch obstruction. And what you can also see by the map on the top left-hand side of the screen is there's a pretty prominent geographical distribution. There's quite a bit of disparity around the country between patients who are prenatally diagnosed and not prenatally diagnosed with heart disease. The group here in Phoenix has also looked at more recently, just this past year, at a similar study, where they looked at a series of various congenital heart defects around the state and found that in isolated arch obstruction, there was 48% diagnosed prenatally, which is fantastic. Probably has to do with all the fantastic work you guys have done here. I mean, probably the lion's share of prenatal heart disease is diagnosed by people in this room. But there still is pretty significant geographic distribution. And so the further away you get from the mothership, the further away you get from expertise, the harder it is to get good prenatal diagnostic testing. And while 48% is a dramatic improvement over 21%, no doubt, there's still work to be done. And the reason why is if we diagnose fetal coarctation appropriately, the outcomes are fantastic, right? So this isn't like a disease with a really difficult cure. You get somebody like Dr. Bell's in the room, the outcomes are fantastic. There's very low long-term morbidity, very low long-term mortality, and kids do great. So what we're charged with is finding the needle in the haystack, right? We're charged with finding a very small needle, like a 2 millimeter needle in a massive haystack. And we don't want to get stuck by the needle when we find it. So we want to find it appropriately. So this is a sinister disease. And so how do we do this? Well, there's a bunch of studies out there. In fact, there's like, massive review papers on this. These are some of the more seminal articles. Again, one by Mike Quartermain, one by Lisa Hornberger, but there's been tons and tons of studies on this. And essentially is when there's right-left discrepancy, you have to be more concerned for coarctation of the aorta. When the arch is narrow, you have to be more concerned for coarctation of the aorta. But one of the more specific findings is not fully right to left flow at the PFO. So if you have bidirectional or left to right flow at the PFO in association with these other findings, you really got to be concerned about coarctation of the aorta. And you can see that the positive predictive value and specificity approach 100%. But later in gestation, that right-left discrepancy gets harder to tease out, right? You can see as you get more towards the late gestation fetuses, once you get to 33, 35 weeks, we look at these and we say, all of these guys got fetal coarctation of the aorta because right-left discrepancy is more than norm. So it gets pretty tricky to tease out. One, again, really nice paper, probably still the best meta-analysis done on this topic was published in Circulation 2017. And this is where they took basically all of the studies on fetal coarctation of the aorta and did a meta-analysis and found that the aortic isthmus z-score, the aortic isthmus z-score in the 3-vessel trachea view, and the isthmus to ductal ratio were the 3 measures that were most consistently associated with the development of coarctation of the aorta. So what we end up with is this sort of algorithm, right? You get a fetus with right-left discrepancy. The arch looks sort of questionable. You're not quite sure. You take that exact same fetus and you give them to 3 different physician groups or 3 different physicians or 3 different sonographers or 3 different neonatologists or MFMs, and you get 3 different pathways of care. On the bottom panel, you get some cool, calm, collected fetal cardiologist who says this is going to be fine, deliver at home or wherever you were going to deliver, and don't worry about it. In the middle panel, you get some group that sort of is a little bit concerned, sort of bares their teeth a little bit and says, why don't we change your delivery location plan? Why don't you come deliver at the mothership, at the tertiary coronary care center? But we're not going to place lines or start PGE. We're just going to treat you as a normal fetus, but we're just going to have you around. And then you get the Edward Monk, sort of Kevin McAllister, hands on the face cardiologist who says, no, this is definitely critical coarctation of the aorta. Let's do a C-section. Let's start PGE, put lines in, and that fetus may not have heart disease. And so there's a real cost to all of this, right? So we want to avoid unnecessary medicalization, but we want to avoid getting stuck by the needle. So this is just a real Gauche treatment strategy. I thought this was a costume party. So what we've done at Stanford is we've developed a clinical pathway. So we've sort of published our outcomes and documented this, but what we've done is we said, okay, whether you have high risk on fetal echo imaging, we're going to identify fetuses at being just slightly increased risk for fetal coarctation of the aorta, moderate risk, or high risk. And based on your risk category, we're going to prescribe a level of care. So for mildly increased risk or slightly increased risk for coarctation of the aorta, those fetuses, we're not going to change your delivery location plan. We're not going to, definitely not going to place lines or start PGE, but we're going to recommend a postnatal echo within the first few days after delivery. And so those fetuses can sort of deliver wherever, as long as there's a pediatric cardiologist who's going to see them within the first few days after they're born. They could go home and then come back into clinic and get care. If you're at moderate risk for coarctation of the aorta, these are fetuses who have anatomic features that are really convincing, but the flow patterns are normal. Those fetuses will get delivered at a tertiary care center, but we're not going to place lines. We're not going to start PGE. We're just going to have them assessed non-invasive. For fetuses with high risk for coarctation of the aorta, those are fetuses who meet moderate risk criteria, but also have bidirectional or left to right flow at the PFO, flow reversal of the aortic arch, physiologic findings that confirm or that increase the risk for coarctation. Those fetuses are going to be placed in our high risk category. They get admitted to the NICU. They also don't get lines or PGE started based on our data, but we aggressively assess them non-invasively, and we get an echo as soon as they're born. And so with this pathway, what we've found is we've been able to reduce inappropriate delivery location changes quite a bit. These are all statistically significant findings. However, I will say that in those without surgical coarctation, so fetuses who would have been fine otherwise, 44% of those still underwent the delivery location change after establishment of this protocol. So still work to be done. Similarly, in those without surgical coarctation, 50% still had umbilical lines. And so obviously there's not universal adoption of the pathway. Anyone who's done QI initiatives knows there needs to be local champions and PDSA cycles, et cetera, still work to be done. But at least we know that establishment of a pathway is possible and does reduce inappropriate medicalization of infants who otherwise would have been totally fine. But there's still work to be done. So we've then looked to the literature and we identified 3 novel metrics that can increase the power of this pathway. One is looking at the aortic arch angulation. This was invented by Bhavna Arya at Seattle Children's. And this looks at the angulation between the ascending and descending aorta and the transverse and descending aorta. And I will say these angles are hard to do. You have to be sort of really trained to do them. And we did that. We invited Bhavna over Zoom and we went through a huge training session and we did that. One of the other novel metrics was fetal myocardial deformation. Anyone who's traced children or adults for myocardial deformation knows how difficult that is. Try doing it in a fetus, it's also quite difficult. But I will say, if you have good images, it's actually not as bad as you would think. And there's actually 2 papers now that show, in addition to ours, that show that this has diagnostic importance. And then finally, in narrow aortic arches or obstructive lesions, we were all used to seeing prograde diastolic flow or prominent diastolic flow. And so this group out of China looked at that in a quantitative way and found that you could distinguish between those with and without coarctation. So we use these 3 metrics in addition to standard metrics like various Z-score measures. And we found that they all improved the ability to distinguish between those with and without coarctation, particularly in the moderate to high risk groups. And that was our goal, is really to identify which of those fetuses who were changing delivery location, who were setting up to counseling the parents if they're high risk for needing surgery, which of those fetuses actually are going to have coarctation. We found that this has diagnostic value, just published this month. But we're still not going to catch them all. So this is a fetus that was recently evaluated at the Outline Center that's affiliated with our center. We reviewed the images and everyone thought this was okay. You can see the Z-scores were all normal, except for the ductus was a little bit dilated. We thought this fetus was going to be fine. They actually were fine initially upon delivery, but within the first few weeks developed surgical coarctation, had to come back for surgery. Way sinister, real sinister disease. The group here has looked at neonatal coarctation. So let's say a fetus is born and now you're trying to determine, is that infant have coarctation of the aorta? How serious is the coarctation? Are you going to approach it from the front? Are you going to approach it from the side? Are you going to put them on bypass? Well, the group here recently had an experience where one of their premature infants developed pretty profound renal dysfunction after a CT scan and subsequent surgery for coarctation of the aorta. That prompted this study in which they looked at agreement between echocardiography and CT or MR and found pretty good agreement between those modalities. We had a similar experience, and so on our end, we've been using non-invasive, advanced non-invasive modalities such as MR without anesthesia. And so these are bundle and feed MRIs, which are motion corrected. The one on the left is an axial T1G, so it's encoded it's radially encoded, which accounts for a lot of the motion that you can see in a non-sedated exam. And the one on the right is a bundle and feed 4D flow study, which again uses flow and anatomy to give you a lot of insight. And so we've been able to do these in about 50 infants without sedation. Moving on to the wide range of outcomes in fetuses with right-left distribution, going to focus a little bit more now on hypoplastic left heart syndrome. As most people in the room know, there's various forms of hypoplastic left heart syndrome. There's aortic and mitral atresia, where the left ventricle hasn't really developed at all. There's the aortic atresia and mitral stenosis, where the LV is developed but has endocardial fibrolastosis and is non-functional. And there's aortic and mitral stenosis, where the LV may be developed, but it's very narrow and sometimes near apex forming. Regardless of the form of hypoplastic left heart syndrome, survival is not great, right? It's about 60 to 76% at 4 years. These data are now a little bit old, but to be honest with you, the outcomes haven't really changed. They're not fantastic. And so we have these fetuses that are seen in our clinic. We counsel them about hypoplastic left heart syndrome. These are the outcomes. This is the life. We talk about liver disease and Fontan, eventual transplant, et cetera, et cetera, et cetera. Families cry. They sort of, go through their whole process of decision-making and whether they're going to continue the pregnancy. They come to terms with it, and they come back to clinic. And then they come back to clinic, and sometimes what you end up seeing is this, which is restrictive atrial septum. So the families have all come to terms with it, with your counseling, but then you sort of throw another curveball at them. Like, actually, your fetus is one of the bad ones. Your fetus is one of the ones where blood enters the left atrium but has nowhere to go. And when that happens, you see a lot of prograde and retrograde flow in the pulmonary veins. And that's a marker of a restrictive atrial septum. And why do we care about this? Well, because the outcomes are terrible, right? So if a fetus has a restrictive atrial septum in association with hypoplastic left heart syndrome, you get pulmonary venous congestion, lymphatic obstruction, and really sick lungs. And that can be manifested on fetal MRI as nutmeg lung. And multiple studies have shown that the outcomes of these fetuses are really, really bad. So this is way sinister. This is a terrible counseling session. And I've been involved in these where the family thought, I thought at least I had a 60 to 75% chance of survival at 4 years. We say, no, it's actually much worse. And so what do we do? Well, what we've now taken the approach where we are going to, what we've been doing for the past decade is maternal hyperoxia testing for every fetus with hypoplastic left heart syndrome. And so we give the moms oxygen during the fetal echocardiogram in an effort to simulate, at least partially, the transition from fetus to infant life. And when we do that, what we found is you can unmask findings consistent with restrictive atrial septum. And so some fetuses, it's quite obvious, and you wouldn't miss it with or without maternal hyperoxia. But there's a lot of fetuses that are on the borderline. And what we found is when those fetuses are on the borderline, maternal hyperoxia can really help you distinguish between those who will develop restrictive atrial septums. So then what do you do? So it's not just about counseling. There are in utero therapies that are available. This is a publication from 2015, again, almost a decade old, but it's a really nice publication because it's an international multi-center registry where they looked at fetuses who had fetal atrial septal interventions. And these are where a needle goes through the maternal abdomen, through the uterus, through the fetal chest wall, through the right atrium, and through the atrial septum. And then they either place a hole or deploy a stent in the atrial septum, which sounds like a great idea. And, sometimes works, but there's still only about 50% survival to discharge, which is not significantly different than the baseline data. So, if the atrial septum is really restrictive or intact and this fetus is going to die, it's probably worth a shot, but far from a well-proven therapy. Still really a real Gauche therapy. This next case is going to really illustrate the sinister nature of left-sided heart disease. This is a fetus who presented at 22 weeks gestation. As you can see in the panel all the way on the left-hand side of the screen, it was a narrow left ventricle, one that looks like that mitral stenosis, aortic stenosis type that we talked about. When you look at the LVOT view, the second panel from the left, the aortic valve is thickened, is echo bright, and when you place color mapping on it, you can see that there's flow acceleration across the valve, consistent with mitral and aortic stenosis. There's prograde flow across the aorta, So this looks like one that'll probably be in that critical coarctation, maybe associated with aortic and mitral valve disease. So that sort of place on the spectrum. So of course we counseled as such, but of course we followed this fetus, and this fetus progressed and got worse and worse and worse. And this is how the fetus looked at 30 weeks gestation. The LV is now shortened, is completely dysfunctional. There's still two papillary muscles, but it's completely dysfunctional. There's still a trickle of prograde flow across the aorta, but not much. And flow in the aortic arch is now all retrograde. So this is the fetus which has progressed from critical coarctation, maybe some aortic and mitral valve disease, now towards evolving hypoplastic left heart syndrome, which is sort of a very typical example of the spectrum of disease, which is seen on the left side of the fetus. Again, just super sinister, way sinister disease. So what do we do? Well, again, there's fetal intervention for this. This is where, again, a needle is placed through the maternal abdomen, through the uterus, through the chest wall, the fetal chest wall. You can see the needle there, eventually going through the ribs right there. There's a poke. You can see the needle there going through the ribs into the fetal chest wall. The fetus is anesthetized during this, and then the needle eventually will, wait for it, will there pierce the LV. Now the needle is in the left ventricle of the fetus. The left ventricle doesn't like that. It's slowed down. There's fluid starting to accumulate around the heart. But we're able to get the needle, the wire across the aortic valve. We're able to get a balloon to follow and to blow up a balloon across the aortic valve. So this is a fetal aortic valvuloplasty, which then resulted in prograde flow through the aorta. And this fetus ultimately had a biventricular circulation, which sounds great. And there's this is again results from that 2015 study in JACC, the results of the International Registry. And they described pretty nice suggested criteria for aortic valvuloplasty in the fetus. However, only 29% of fetuses in this registry who underwent fetal aortic valvuloplasty were discharged as the biventricular circulation. And amongst those discharged as the biventricular circulation, that doesn't mean that they're normal, right? Many of those have very elevated filling pressures. Many of those need aortic and mitral valve surgeries. So this is far from a panacea. So pretty Gauche disease, a pretty Gauche treatment strategy, pretty awkward and not refined. That being said, the outcome data have actually gotten better over the years. So these are two different cohorts. I don't want to, it's sort of comparing apples and oranges, to be honest with you. The prior data were results from International Registry, which did not include Boston Children's. These are updated results from Boston Children's. And as you can see, over the years, we as a field have gotten better and better and better at this treatment strategy. Right now, if you look at the most recent cohort, survival to about 5 years is pretty good in the fetal aortic valvuloplasty group, and is much better than the single ventricle group, suggesting, and as you can see in the panel on the right, therapies have gotten better, survival has gotten better, outcomes have gotten better in this disease cohort. So, you know, still a lot of questions out there, but I will say this is probably one use case which has gotten better over the years. I'm going to finish the discussion on fetal cardiology with a just one slide on a study that I had the good fortune to be involved with. This is work by Haley Miller, who's an obstetrician and MFM at Stanford. She looked at the impact on the Dobbs decision on the number of births with single ventral congenital heart disease, the numbers of heart surgeries, the number of transplants, ECMOs, and deaths. And one of the reasons I love this study is it's, in some sense, it's apolitical, right? And obviously everything's political. There's going to be implications on both sides, for sure. But these are the data, right? And so we have whatever comes down the way, whatever sort of decisions are made on a national stage, whatever decisions are made on a local stage and state by state, we have to be ready for what's going to come. And so this is just some insight in what's going to come. So there's going to be a dramatic increase, of course, in fetuses born with single ventricle disease, a dramatic increase for the number of heart surgeries, number of heart transplants, the number of ECMOs. And so we have to be ready financially, and we have to be ready from a resource perspective. I had the good fortune to speak with some of your colleagues this morning, and I think many hospitals are similar to ours, where we're counting the number of beds with a fine fine pencil, because there's no resources right now. Everything is full to the max. And so regardless of what your political leanings are, whatever the outcomes of these decisions are, we just have to be ready. So the most sinister of all. So we're going to move on from fetal disease but stick with the left side of the heart. And these are cases of sudden cardiac events on the playing field. There's been a recent increase over the past decade or so with concerns about sudden cardiac events that have occurred in pretty high profile situations. The number one cause of sudden cardiac arrest in the young athlete is hypertrophic cardiomyopathy, but the number two cause is coronary artery anomalies. And I would posit that these are like the most sinister of causes, and we'll explain why in a second. Coronary arteries, typically, the normal pattern is seen on the left, where the right comes from the right sinus and the left comes from the left sinus. An anomalous left coronary artery, the left coronary artery arises from the right sinus and typically goes intra-arterial and intramural. There's other patterns as well, but most typically will go intra-arterial and intramural. And then an anomalous right coronary artery seen on the right-hand side of the panel, where the right coronary artery arises from the left sinus and most typically, again, goes intra-arterial and intramural. So this is a little bit fun with numbers. Nothing is fun when you're talking about children dying on the playing field. I don't want to suggest that is fun, but some sort of numerical fun. Sudden cardiac death itself is quite rare, thankfully, right? So in the general population, it's about 1 in a million, 1 in 100,000. So thankfully, very, very rare. Coronary artery anomalies are present, if you look at autopsy studies, are present in about 17% of sudden cardiac death in athletes. Which sounds bad. That sounds like that's a really bad, and it is bad. Now, that being said, coronary artery anomalies in the general population are relatively common. Some studies, Dr. Angelini, when we were in Houston, did a study where he's found coronary artery anomalies are as common as 1 to 2% of the population. I don't think they're that high. It's probably more like 0.2, 0.3%, but relatively common, maybe even 1 in 1,000, right? So dramatically more common than sudden cardiac death. So if you put those numbers together, and again, putting these data sources together is a bit dangerous because you're taking data from one study, data from another study, different settings, different patient populations, et cetera. But if you do that dangerous work in your head, the estimated risk for sudden cardiac death from a coronary artery anomaly is about 0.17 to 0.35% in young athletes over 20 years. Anomalous rights are about 6 times more common than anomalous lefts in the general population. But on autopsy studies, anomalous lefts are about 4 times more common than anomalous rights. So if you put all those numbers together, which again is sort of dangerous, right? So like these numbers, please take them with a grain of salt, but they're the best that we have. So if you put all those data together, the 20-year risk of death with an anomalous left coronary artery is about 6%. And from anomalous right coronary is about 0.2%, which is not very high, right? 0.2%. It is higher than the 1 in 100,000 of the general population, but it's not super high. But this is sinister disease. This is really sinister disease because when you're counseling the family sitting across from you, they think that a surgery is a cure, right? And so there's different surgical options available. One is an unroofing procedure where the sort of intramural course is opened up, oftentimes across a commissure. The other is direct reimplantation, where the anomalous coronary artery is reimplanted into the appropriate sinus. And there's other therapies for sort of more rare forms of anomalous coronary arteries, but those are the 2 most common. These are data that we literally just, as I took over the anomalous coronary program, just started gathering, and literally I got these data like 2 days before my trip here. So they're unrefined data, unpublished. But over the past almost 20 years, we did 227 coronary artery surgeries at our centers, most of which were reimplantation. A decent number were unroofing, and the number of reoperations were low, very low. Now, that being said, we haven't done robust and responsible quality control or follow-up, which we will do. So please take these with a grain of salt. These are only the reoperations and the concerns that we know of. But I think these are some data that suggests that the procedure is actually somewhat safe. These stand in contrast to the recent CHSS study that was published just this past year in 2023. And this was a study done of almost 400 primary repairs. And what they found was the risk for an adverse event was anywhere from 7 to 13%, depending on what you count as an adverse event, right? So maybe some of these were mild aortic insufficiency, which, big deal. So they had mild aortic insufficiency. But some of these were new abnormal ejection fractions. Some of these were a positive ischemic test. And 1% of these were deaths. So fairly sober, it's a pretty high number when you compare these to the alternative, which is 6% in anomalous lefts and 0.2% in anomalous rights. So what do we do, right? So when the patient is sitting across from you, when the family is sitting across from you, asking what they should do, there's option number one where you offer them surgery, and you tell them like, yeah, most kids do well with surgery. We don't really know long-term follow-up. Surgical techniques have been refined and changed over the years, but we think that the long-term outcomes are probably good as long as you get through that initial period. But there's a 7 to 13% chance of an adverse event. That's door number one. But after surgery, according to AHA and recent JTCVS guidelines, patients can now participate in all competitive sports. So that's enticing. Door number two is you just offer them exercise restriction and say, we're not going to put you through surgery, but we don't want you to participate in intense competitive athletics, which sounds great. But many parents, many kids think of intense competitive athletics as anything. And so now you've turned a kid who was pretty active kid, who was an athlete, who was on the soccer team, who enjoyed sports, and you've turned them into a couch potato. And that has pretty dramatic effects on their mental health and pretty dramatic effects on their physical health. And then the third door is no exercise restriction and no surgery, which is probably the right answer in the vast majority of cases. But it's a bitter pill to swallow. It's a very difficult thing for a family to know that their child has an increased risk for sudden cardiac death, but we're sure you'll be fine. Like, don't worry, it'll be okay. So again, very, very difficult choices. Sounds good when you read the guidelines, when you read the guideline recommendations, but so gouge, so awkward. Not a great approach. So that being said, guidelines do exist, right? So surgery for anomalous lefts, that is intraarterial and intramural, which is the majority of anomalous lefts, is supported. And that's what we do. We operate on all anomalous lefts. And anomalous rights indications for surgery include symptoms of cardiac ischemia with exercise, which again sounds great, right? If you have symptoms, we'll operate on you. But when you sit across the table from these parents and these kids, it's not that easy to tease out. Many kids have had maybe chest pain once or twice, not sure if it's associated with activity or not. And so it's very difficult to tease out. Oftentimes these kids come to cardiology with symptoms, but those symptoms may be palpitations or some random chest twinge that maybe occurred at rest. Maybe they have precordial catch. The cardiologist did an echo just to make sure, and lo and behold, there's an anomalous coronary. And so what does that mean? So it sounds great when you read the guidelines, but it's oftentimes difficult to practice. Positive results on stress testing are a little bit more obvious, especially exercise treadmill testing, but these are rare. The vast majority of kids, even those who get surgery, will not have positive results on stress testing. If anomalous rights are asymptomatic and have negative provocative testing, return to competitive sports are reasonable, which again is probably the right answer in the vast majority of kids that we're going to see in our clinics with anomalous coronaries. But it's a very difficult thing to do as a parent, as a physician, to sign that paper saying okay to participate in competitive sports, knowing that they have increased risk relative to the general population. And so we've gotten a little bit more refined in our evaluation. These are all, the data behind these practices are all suspect because just the nature of the disease is you're never going to have a large population of children who've had intense preoperative diagnostic testing and then died, right? You're just never going to have that population of patients. So everything we do to study these children is going to be limited. But one of the things that we're doing, we as a society and we institutionally, is using CT. And we rely pretty heavily on CT to help us decide which patients to operate on, which patients to not operate on. Probably the most important CT aspect is the length of the intramural course. As you can see, the lengths of the intramural course correlate pretty well between CT and intra-op measurements. And there is a difference between those who have longer intramural segments and shorter intramural segments between those who do and do not have symptoms. So there's some, and there's others data that support this as well. This is one of the data points out of the CHSS cohort. But there have been other studies on this, and this is generally well accepted as one of those higher risk things, particularly in anomalous right coronary arteries. One of the other aspects that's oftentimes used is a slit-like ostium. Although I will say that these are a little bit tougher to tease out. With anomalous left, it's a little bit easier to tease out because many of them have slit-like orifices and many of them go to surgery. So in that case, in that sense, it's not as helpful, but it's a little bit easier to tease out. In anomalous rights, the vast majority of anomalous rights that we've seen have slit-like orifices. And we know the vast majority of anomalous rights are going to be fine and not need surgery. So if you start using these as one of your criteria to operate, you're going to end up operating on the vast majority of kids with anomalous rights. That being said, you can use cross-sectional imaging to diagnose slit-like ostia, and some people are using that as one of their as a basis of whether or not to operate. So in summary, left-sided heart disease can be way sinister with dynamic and insidious presentations leading to Gauche treatment strategies. Though I will say that we are doing things to get better, and I hope I've shown you today that the groups here, our group, and groups around the country and around the world are really making advances in left-sided heart disease. Left-sided heart disease is a spectrum and can evolve during fetal life. There's certainly fetuses at risk for coarctation. They're at risk for over-medicalization. Infants with hypoplastic left heart syndrome have a wide spectrum of outcomes, with restrictive atrial septum being amongst the highest risk of those with hypoplastic left heart syndrome. Anomalous aortic origin of the coronary artery is frequently benign, although there is an association with sudden cardiac death. And current recommendations do support elective surgery for anomalous lefts that are intramural and intraarterial, and anomalous rights with symptoms or positive findings on provocative tests. With that, I'll thank you for your time. These are my acknowledgements and just some photos of our team having fun. Thanks a lot.
Yeah, I think we have some time for some questions. So please, audience, please raise your hand. Make sure you can read the question for the Zoom.
Oh, yeah. Yes, sir. Arash, Dr. Sabati.
Great talk. On your fetal QI project, was it just your group at Stanford that you had, or did you have to get buy-in from outside providers, groups, MFMs, to kind of follow the protocol? And then how did you leverage that in a complex area like the Bay Area, where there's so many hospitals and so many centers and so many providers?
Yeah, great question. Great question. So the question is, for the clinical pathway for fetal aortic coarctation, did we have to leverage and input from and buy-in from practitioners and MFMs and neonatologists around the region? And the answer is yeah, we definitely had to. We deliver our, all of the fetuses that we're concerned about, the moderate or high risk fetuses deliver at Stanford, but we have a delivery center. But those that are mild risk would deliver in the community. So places as far as Modesto, Salinas, we have an affiliation with Sutter. And so Alta Bay, which is a hospital in the East Bay, is a major delivery location for us. And so we had to get buy-in from not only the pediatric cardiologists, but the MFMs and neonatologists who support those hospitals. I will say, like, people were hungry for this, right? So people sort of knew that this was a problem. They all had moms who, this diagnostic entity of concern for fetal coarctation was pretty common. And so patients were told their fetuses could have a problem, were transitioned to deliver at Stanford, had to stay in the Ronald McDonald House, had to deliver their baby there, had to upload their lives, be away from their families, be away from their kids, and then lo and behold, everything was fine. And so they heard that feedback from their patients. And so people were hungry for this. This wasn't something that came out of left field for them. And what that also meant is that this actually was a shift where they could keep a lot of their deliveries. And so even from a financial standpoint, this made sense for them. And so it wasn't easy, it wasn't hard to sort of develop that buy-in, because not only was this better for patients and their families, it was actually better for the delivering obstetricians as well. Do they get that delivery? Yeah, Chris.
Great talk, Shiraz.
Thank you.
So you mentioned the financial aspects. I know Bhavna has done a cost utility analysis and their team in Seattle. Can you just comment if you've done any of that analysis in your practice in terms of using PGE inappropriately, or how many fetal echoes are done, and what does that look like in your setting?
Yeah, great question. So the question was, Bhavna, Arya, and their group in Seattle did a cost effectiveness analysis where they were able to demonstrate that the most effective strategy would be a single fetal echocardiogram and then a subsequent postnatal echocardiogram, as opposed to repeat fetal echocardiography, and if we had done anything similar. And we haven't done a formal cost effectiveness study, but we did look at the number of fetal echocardiograms done, and it was actually pretty similar before establishment and after establishment of our pathway. And I think one of the reasons was, in order to make things sort of systematic and protocol driven, we said, okay, that the echocardiogram that we're going to use for risk stratification was going to be the closest one to 30 weeks. And so if they had a single one at 23, 24 weeks, all of those got a repeat study at 30 weeks. And so that would be a cause to increase the number of fetal echocardiograms. Now, that being said, there was also many fetuses who, prior to the pathway, people just didn't know, and so would scan them again and again and again. And so at least the pathway gave them a structure, and so that decreased it. So overall, the effect sort of washed out, and we ended up getting a pretty similar. It was something like 2.3, 2.4 fetal echocardiograms per case, but it wasn't different between prior to establishing and after establishing the pathway in terms of the number of fetal echocardiograms. We were able to decrease the number of delivery location changes, the number of umbilical lines placed, and the medical instrumentation. So that, of course, has a cost benefit, but we haven't sort of described that in any sort of official cost benefit analysis. Yeah, Dr. Bells.
Simple question, how along those lines? Two questions. What's the downside of changing location? It's like asking how the insurance is. You don't have a car accident. The change location is very kind of problem. You don't want to go watch your bike. So that that's number one. And number two, has your structural group changed from implantation? It seems that I got into bone recently. There's always something around the bed.
Mm-hmm.
You know, that implantation. As long as you don't that change.
Yeah, great question. So thank you very much. So Dr. Bells had two questions. The first I'll tackle is about delivery location change. So what is the harm? Who cares, right? So the mom has to change locations, but Stanford's a nice hospital. Palo Alto is very nice. They get to sort of deliver at a nice place. And I would agree, it's a nice place to deliver, but not that I'm doing the delivery, but I will say it is a major impact for a lot of moms, because you got to remember, these moms have other kids, they have families, they have lives, and to have to and oftentimes delivery can happen pretty quickly. And so if you're in the Salinas area and we're asking you either to drive an hour and a half or 2 hours, maybe through traffic while you're in labor, to come up to Stanford to deliver, that's treacherous. And so then we may ask you to stay local. So then we're asking them to move from their home, from the place where they have all of their support systems, to deliver at a different location and to live there for a few weeks, because we don't know when you're going to go into labor. So if we're asking them to move, we're asking them to move at about 36, 37 weeks. So for a few weeks, they're living away from their families, away from their lives. It's a big upheaval.
And
Yeah, when we talk about delivery location changes, we're talking about a place with a surgical center. And so for the moderate and high-risk fetuses, we're asking them to deliver at Stanford. We do have an affiliation, as I mentioned, with Alta-Bates, which is a pretty high-level NICU. You know, they don't have a surgical center, but, you know, there are pediatric cardiologists who staff there. There are people who can diagnose and put patients on PGE, similar to a lot of hospitals in the area. But if we have a pretty high suspicion that a fetus is going to, just generally speaking, we have a pretty high suspicion that a fetus is going to need surgery in the neonatal period, we'll have them deliver at Stanford. Just because we want the family nearby, we want the moms nearby. It's always sort of leaves a bad taste in our mouths when we're operating on a neonate and the mom is postpartum at some other place. So that's the reason for the delivery location thing. And that was actually a major outcome for that project. In terms of the second question about reimplantation versus unroofing, we haven't moved away from reimplantation. We are, as you saw in our data, we're very heavily in the reimplantation group. And the reason why is we've had a couple of cases that came back after unroofing with continued ischemic changes. And when we looked at those cases on CT scan, we found that the ostia weren't nearly as large as we thought they were after unroofing. And so there was probably some residual dynamic changes to the ostium or to the intraarterial course, which prompted those symptoms. And so then we've taken those patients back to reimplantation. When we look at postoperative CTs in those cases, the reimplantations are just so much more attractive because they look normal, you know, as opposed to an unroofing where they're still anomalous. And yes, there's a wide open ostium, but they're still anomalous. And so, and you know, to be frank, our surgeons are just fairly comfortable with it now. They've gotten to the point where they're anastomosing really tiny vessels in, you know, MAPCA's cases and anastomosing really tiny vessels in aortic root reimplants. And so those sort of surgical techniques, they've sort of been very comfortable with, not just Dr. Hanley, but all three of our primary surgeons. And so they haven't actually said that it was any more difficult than an unroofing procedure. Yeah, Wayne.
Mine, Shiraz, regarding your congenital coronary anomaly program, could you just describe what divisions, who was involved in that, and maybe your workup, including preoperative testing, nuclear scans, stress MRI?
Yeah. So, you know, so the question was from Dr. Franklin, if, can we just describe the program, the vision of the program, and what sort of provocative testing we do. And so I'll say our program from a surgical standpoint is very mature, right? We've been operating for decades. We have a really large patient population who's had surgery. Our program from a medical assessment standpoint is very, very young. Just this year, I took over this program. So we're still in the process of developing all of those diagnostic modalities. We still don't have dobutamine stress MR, which is sort of a linchpin of at a lot of centers. I know you guys have the access to dobutamine stress MR here. The Texas group has published extensively on dobutamine stress MR and its implication. It's definitely not a panacea. It's for sure not the one test that's going to tell you what to do, but it's just another tool in the toolbox to help you make a decision. So right now we're working on implementing that. Our current workflow is very CT heavy. We do have stress echo, and so we use stress echo to assess for regional wall motion abnormalities. And then of course we use treadmill tests. But I will say we have not had a positive finding in either of those as I've taken over the program. So it's pretty, and even in the literature, it's pretty rare to see a positive stress treadmill or a positive stress echo. The majority, about 10% of patients in the entire cohort, including anomalous lefts, will have a positive finding on stress MR. So I think that is a modality that could help tease out which of those are going to be are going to merit surgical intervention. Although I will say 10% is also still pretty high, right? Only 6% of anomalous lefts and 0.2% of anomalous rights are going to have sudden cardiac death, and 10% is still a pretty high number. Yeah, Dr. Pattis.
Great talk. So, following up on Wayne's question, do you do any provocative testing after the repair to say who can return to sport, or is it once it's fixed, it's deemed fixed?
So at this point, so the question was about proactive testing after repair. And so at this point, that is all up to the primary cardiologist. And so we get a lot of referrals from outside cardiologists or even cardiologists within our group, and we sort of leave it up to them. We're currently working on that strategy. What I do in my practice is I'll get a CT scan it depends on what it is. If it's an asymptomatic anomalous right, I'll get an exercise stress test afterwards, but those are going to be fine. They're going to be normal, and then we'll release them to play. If it's something more complicated, like we've recently had a rash of intraseptal lefts, which with really weird proximal courses. And so those I've had CTs on afterwards and done provocative testing afterwards before releasing them to play. So it kind of depends on for me personally, it kind of depends on the anatomy that you're starting out with.
That's in line with the data, the data from CHOP, that 60% of those anomalous lefts that are, I think they're mostly unroofed, as you said, have persisting perfusion defects after their surgical, whether it be from the unroofing or damage that was done prior. So the majority, even after you repair them, if they had ischemia or perfusion defects before, will have it afterwards. So.
Yeah. But the question is, what do you do with those patients?
Yeah, I don't know. Pray.
Yeah, Jordan.
With respect to diagnosis of neural, but stored. Specific. We're looking at CTs or
Yeah, great question. So Jordan asked if generally speaking, what are the pitfalls of diagnosing an intramural by CT? And I think it's important to remember when we say intramural, what we're looking at is the lumen, right? A CT scan is essentially a luminogram. And so we're not actually seeing the aortic wall, right? So we actually don't know how much of it is actually intramural. What we're doing is we're looking at the proximal course of the coronary, how narrow it is, and when it dilates out. And we're sort of inferring based on what we're seeing on how narrow the lumen is proximally, how much of it is intramural. So it's a bit of a guessing game. But I think the major, what I found most helpful is just really high quality imaging. So better spatial resolution, a better breath hold, a slower heart rate. The older kids, the ones who hold still, the ones who can take a deep or who can hold their breath and arrest motion the best, you have better data. Which is not the only reason, but one of the reasons why when we get these referrals for 6-year-olds and 7-year-olds, I tell them, well, we're just going to see you again in a few years. We're definitely not going to do anything now. The other reason for that, as an aside, I know this wasn't your question, but the other reason for that is the highest risk for sudden cardiac death is between 12 and 30. And so it's very uncommon to even see case reports of children less than 10 or 12 years old who've had sudden cardiac death. And so we get these referrals sometimes of babies, sometimes of 2-year-olds, and we just tell them to hold off for a good number of years. Yes, sir. Yeah, the short answer is I have no idea. The long answer is my guess is, parents often ask me this is, why does it end at 30, right? So what happens at 30? And I say, listen, at 45, I'm sure I'm less healthy than I was at 30, but I definitely don't do as extreme exercise, right? I'm not sprinting out on the field as much as I was back earlier on. And there's probably also a survival bias, right? The ones who are going to die probably died between 12 and 30 when they're at their peak physical activity, when they're doing their most intense competitive sport. And then the ones who are going to live have lived, the survivors have lived. So I think it's probably a combination of those things, Arash.
Yeah, so part of it exactly is that, and part of it is the amount of exercise that's being done by a 9 and 10-year-old. Most 9 and 10-year-olds is far different than when they get through puberty and they're starting to engage in far more competitive sports. So theoretically, if you've got a 9-year-old that's doing, extreme club soccer, that they're super competitive, that may be on a travel team, that may be a kid that's actually gonna be able to push themselves to, having an event at a younger age. So that may be a kid that you can screen earlier. I mean, it's kind of like when we put these really young kids on the treadmill, they just putter out, they just stop. Which is why, for the most part, a lot of, organized sports are much different before varsity and high school sports, is just the ability to push the child to a certain limit. That being said, not all of these events happen at maximal exercise.
That's true.
Right, some of these events can happen during training. These events can happen at sub-maximal exercise, so there's physiological reasons.
And there's a gender difference.
They're more common in males though than females. There's a male predominance of the coronary artery anomalous.
Okay, interest of time, we'll have to wrap it up here. Thank you so much, Dr. Maskatia. Thanks everybody for coming. We're going to give a little break, and then we can continue in our echocardiology lab here. Thank you.